Hello, everyone. My name is Nicole. I am here today with my colleagues Erin and Mizuho, and we're here to talk to you guys about challenges in accessing end-of-life care and palliative care for patients. Um, Even though there is strong evidence behind palliative care and its effects, many patients who could benefit from palliative care don't ever end up receiving it, unfortunately. So today we'll be exploring why these barriers exist and how advocacy, especially from a social work perspective, can help address them. So our target audience is Michigan Medicine. To narrow it down a little bit, we are specifically aiming towards Michigan Medicine leadership, including policymakers, providers, and administrators. These specific groups shape how palliative care is funded, referred, and integrated into a patient's care. Advocacy at this level has the potential to improve access on a system-wide scale, especially for patients who are most likely to be underserved and not have access at all. So, why Michigan Medicine? We chose Michigan Medicine because it's a large, integrated academic healthcare system. It has it has influence at multiple levels, including clinical practice, workforce training, and institutional policy, um, which is all in the end related to a patient's end-of-life care. As both a care provider and an academic institution, it is uniquely positioned to address barriers like delayed referrals and lack of interdisciplinary care in a patient's treatment plan. Advocacy at this level has the potential to create system-wide change that will extend beyond just one hospital. Finally, Michigan Medicine is not just a place where care is delivered. It's also a place where future physicians, nurses, and social workers are educated and trained. So the challenges we are presented with, early palliative care is proven to be the most successful to provide physical and emotional comfort for patients. But it is consistently underutilized and usually started too late for patients. There are some barriers to accessing palliative care. The main barriers are structural and institutional, being system fragmentation and workforce shortages. Also cultural access. There's some dominant medical norms out there that can significantly delay end-of-life discussions. So some primary objectives: we want to identify the root causes of delayed care, and we want to provide actionable reform strategies for policymakers, healthcare providers, and leadership. Our ultimate goal is trying to shift towards a system that prioritizes patient-centered care and dignity during the final stages of their life. Why accessing early palliative care matters. All of this being said relies significantly on the timing of this care which is received. Research often highlights how palliative care works alongside curative treatment, not just at the end of treatment. Oh, I'm sorry. I'm going to pass this along to my colleague, Mizuo.
Key insight into end of life care, conflicting objectives. One common challenge in serious illness care is deciding between quality of life and length of life. Patients and families are often asked to choose between aggressive treatment or comfort-focused care. While these goals don't have to be opposite. The healthcare system often treats them that way, which can lead to stress and care that doesn't fully match what patients actually want. This tension helps explain how palliative care is so important. Role and timing of palliative care. In response to this challenge, palliative care helps address the tension by focusing on comfort, symptom relief, and emotional support rather than just extending life. It can be provided alongside medical treatment, not just at the end of life. Research showed that the earlier access to palliative care leads to better outcomes for patients compared to late or no referral at all. Despite these benefits, access to palliative care remains limited. Next slide, please. Systemic barriers. Even with strong evidence, access to palliative care is still limited. This partly due to medical culture, which often prioritize curative, curative treatment and due to structural barriers like limited training, reimbursement issues, and geographic or socioeconomic inequalities. Challenges in the BHA. These barriers are especially clear in the BHA. Late referrals, staffing shortages, and inconsistent understanding of palliative care often delay symptom management and reduce quality of life for serious ill veterans. Because of these ongoing challenges, policy level solutions are needed. Next slide, please. One important policy solution is to expand palliative care training and education. This includes investing in education across disciplines, physicians, nurses, and social workers, and making basic palliative care competencies a standard part of clinical training. Doing this can encourage earlier referrals and help ensure care is truly patient-centered.
Okay, I'm going to talk a little bit about implementation strategies. So, we want to be able to demonstrate that expanding palliative care is operationally achievable. It's not just a theoretical policy idea that we can actually, make this happen with actionable steps. To move from policy ideas to real world change, we need research that identifies specific strategies that help organizations successfully implement palliative care interventions, like, for example, at Michigan Medicine. So, some of the key areas that will be focused upon: facilitation, looking at either internal or external experts to help implement elements of guidance, also help overcome knowledge gaps and resistance. Second talking point area of importance is education and training, looking at different ways we can build clinical competency in end of life care, as well as support consistent understanding across all disciplines. Number three, internal engagement, leadership and frontline staff buy-in is very critical, as well as helping to integrate palliative care into routine practice. Number four, looking at external engagement, What does collaboration look like across specialties and the healthcare system as a whole? And looking at different ways that we can improve continuity of care and also referral pathways into different places that can be helpful for the client. These strategies reinforce why our group focused on workforce training, because education is the foundation that supports all other system improvements. Again, taking policy ideas and creating them into actionable steps. Next slide, please. So there are certainly some advantages and disadvantages that we wanted to go through. We want to demonstrate and show a balanced policy analysis, not just the benefits, but again, real world actionable steps that can be taken and some of the challenges that may be apparent as we go along this course of action. Some of the advantages look at, addressing workforce shortages and inconsistent clinician knowledge, improve system-wide quality and coordination of care, supporting professional organizations as well as academic institutions like Michigan Medicine, for example, is also a world-renowned academic institution. It's a teaching hospital as well as a normal hospital that provides care for everybody in our community. That's extremely important to have both of those available. Strengthening interdisciplinary collaboration is very critical in palliative care as well. Some disadvantages, looking at long-term funding and institutional investment can be an issue. Does not necessarily immediately increase patient access. Some possible curriculum resistance or training overload, since Michigan Medicine is an academic institution where there is training of doctors in residency, so that could be an issue potentially. Risk of uneven implementation across the healthcare system as well could potentially be a downfall. Even with these system challenges, workforce training, in our opinion, is still one of the few strategies that can produce sustainable systems level change. So we hope that this brings us to the important message of our presentation, which ultimately needs to change in how we approach end-of-life care. Next slide, please. Our final takeaway. So the central takeaway that we hope that you get from this presentation is that we feel that the biggest barrier to palliative care is not necessarily evidence, it's systems and culture. Okay, so how can we reshape those in order to improve not just the staff and the administration at a hospital, but the care of the clients that we are serving in our community. Strong evidence really supports early palliative care can be effective. Barriers persist because of medical culture that prioritizes life-prolonging treatment. Workforce training gaps are, certainly an issue as well. Structural inequities and system fragmentation. We need to bring systems together so everybody's talking appropriately, bringing all the information together for a client in order to do what is best for that client. Large systems such as Michigan Medicine, or even like we mentioned in an earlier slide, the Veteran Health Administration, these academic or medical centers can sometimes have barriers that play out in practice. We really hope to expand interdisciplinary palliative care training as our, again, actionable step for policy recommendation. We hope to improve long-term care coordination, improve equity and patient outcomes. So getting people to live longer, but also that quality of life is extremely important as a part of that process, not just the extension of life, but that quality, meaningful time as the individuals may pass on. Aligning healthcare needs with dignity and patient-centered goals. So what does the patient and the client really want? What do they need? And have them work in partnership with their palliative care team to ensure the best outcomes for them. As we kind of talked earlier, we hope that more equitable access across palliative care will be started by training clinicians to recognize when and how to integrate them. And I believe that is it. Thank you very much for coming for our presentation. And we hope to, here's our sources, some of the resources that we relied upon for our presentation. And again, this was a pilot for us to start with Michigan Medicine, but we hope that is potentially replicatable to other institutions like maybe the Ann Arbor VA or the Detroit VA or other types of medical centers that could really benefit from this type of information. And that's all we have. Thank you.